diagram shows the patient that they with neurogenic thoracic outlet syndrome and venous thoracic outlet syndrome that they underwent the first strip resection. You see that they're pretty, both groups, they were able to resume their baseline activities within a short course of the time, and then they're able to just have a resolution of their symptom with obtaining the functional sort of capacity. So for the one, this study actually is a very interesting study done by Johns Hopkins, because Johns Hopkins is the tertiary center, so they were getting these patients referred after the acute phase, and they're getting for first strip resection and try to just help out this patient, but the big group of these patients are coming after the acute phase. And then what they see here, that if for the patients that they stay on the anticoagulation outside the acute phase for a long time, or the people that they had they had the intervention initially with restoring the fluid but didn't get a first strip resection, the result is pretty close. That takes us back that I think we need to focus on this patient more in acute phase, and then when they come out of the emergency room to have a plan set up by vascular specialists. So this is our patient. 2 weeks later, underwent a surgical decompression, resection of first strip, and then the coastal with clavicle ligament also resected as part of that, and then anterior scalectomy for the patient. He's doing pretty well, so we put him on Eliquis, apixaban, 5 milligram twice daily for 3 months. I dose reduced him to 2.5 twice daily after 3 months. He continued to do well, and he's coming for follow-up. His ultrasound didn't show any recurrence event, and he's very happy with restoring his functional status, which gradually happened over the course of about 3 to 6 months. So before I go to the next patient, if any comment, anything that
I'm just
you want to
curious.
add?
Does that have, that last case have a lot to do with hypertrophy of the muscle too?
That's true. In some patients, the apathic patients, you may see the hypertrophy of skull and muscle by itself. It could be a component of compression. In patient, we do see it in patient with the venous type, but you can see it more in a patient with neurological TOS more commonly. But as a part, Gene is a surgeon, he can comment on it. We always try to take care of the skull and muscle as well, because it will reattach there. It can't, create another compression site there, and usually they shorten the skull and muscle. You do it, I don't do it.
Right. Yeah, there's two. Well, there's the first resection, because you have to decompress it, right? So I've had patients that came to me after having a DVT. They open it up, but then someone places a stent in there thinking that it's going to stay open. It doesn't stay open. In fact, it's usually days after it shuts down again. So you have to decompress that and actually create that room so that you can, now after that, you can go ahead, if you still need to, you can put the stent in there. And the other thing that I actually will start to entertain is, which is a little less traumatic than a first rib resection and less litigious, is a medial claviculectomy, taking out the medial head of the clavicle, which also, instead of decompressing from below, you decompress from above. And really these patients, if they're young, you might do the first rib, but when they're older, the clavicle really, they're not going to be lifting weights, right? Mm-hmm. So they do fine, even with removing the clavicular head.
So when I start my practice, I start talking to the emergency room doctors about what I'm talking to you, and then they start being more attentive to it. And I'm turning my head and I see, I get like 2 or 3, 4 of them in my practice a month coming from the emergency room of the Evanston that I practice, and I said, they're there, but sometimes they overlook because nobody look at it the way that we just review them.
One question. I know that some of these patients get discharged from the hospital on Coumadin, apixaban, or Xarelto. Any preference as to right or wrong?
So I think going for the anticoagulation, as long as this is completely a primary and anatomical problem, and there is no other comorbidity involved, so they're suitable for placing them on placing him on the direct oral anticoagulant if you're aiming for anticoagulation. However, if this patient's coming for intervention, I think it's better, my preference is to put them on a short-acting. I usually, if we're deciding to do the venogram tomorrow, 2 days from now, as an outpatient, which I'm now moving them, if they're not very symptomatic, we bring it back for a venogram within 2 days, 3 days sometimes. If you don't want to get them admitted, I put them on Lovenox, and that's much easier to handle because the long-acting, rivaroxaban or apixaban, usually, like, it takes you time, especially if you're going to start a lysis, you don't want that to be like, in his or her body. So that's what I prefer. But if we go for inpatient, then you can even consider the heparin. But if you're intending to anticoagulate only, I think you can use all the new oral anticoagulant as long as they have a right weight, as long as they have a right kidney function, and there's no medication interaction.